Hi, everyone, and welcome to today's webinar, The Collision of the Opioid and COVID-19 Public Health Crises, a West Virginia Perspective. I am Carol Dorn-Sanders, Senior Vice President of Marketing and Communications for DisposeRx, and we're delighted to have you here today. This is our third in a series of webinars focusing on states that have been severely impacted by the opioid epidemic and now the pandemic. We did previous sessions focused on Ohio, as well as the Commonwealth of Kentucky. And today we will be focused on the state of West Virginia. We've assembled a panel of incredible leaders throughout the state. We're delighted that each of you is here with us today. And without further ado, I'd like to introduce you to Courtney Hunter. She is a Vice President of State Policy for Shatterproof. We had the pleasure of having Courtney with us at a previous session. She brings with her incredible knowledge and experience in this space, and we're delighted that she'll be leading our discussion today. So Courtney, thank you so much for being here and helping lead this discussion with this panel from West Virginia.
Thanks for having me. As Carol said, my name is Courtney Hunter. I'm the Vice President of State Policy for Shatterproof. Shatterproof is a national nonprofit dedicated to reversing the addiction crisis. And I'm so excited to chat with all of you today who are making such an impact in your state and in your communities across West Virginia. So, we know that COVID has had devastating impacts on everyone's life in the past year, particularly those struggling with addiction. And according to the American Medical Association, West Virginia is one of 40 states reporting increases in opioid-related deaths in recent months. And according to a recent opioid overdose study conducted by the CDC from May of 2019 to May of 2020, West Virginia saw a 22% increase in overdoses compared to the same time last year. So we really thought before the pandemic we were making strides, and this has set us back a little bit. And we really have to be creative and invest resources in this problem. West Virginia's leaders at the federal, state, and local efforts who have been active for more than a decade fighting the opioid crisis and have sought public and private funding to support initiatives to protect their citizens, as well as prevent injury, addiction, and death. While their efforts have been heroic, the COVID-19 pandemic thwarted many of the programs and plans that were in place, causing setbacks in progress to be made. So today we've assembled a distinguished panel of guests who are working tirelessly to improve the lives of those in West Virginia. They are unique in their roles and organizations, but they all share in a common commitment to address addiction, the opioid crisis, and now the COVID-19 pandemic. So serving on the panel today are Mayor Steve Williams from the city of Huntington, Nick Mercadante, co-founder and CEO of Pursue Care, Casey Cesnovar, Vice President of State and Local Government Relations for Walgreens, Krista Capehart, Clinical Associate Professor and Director of the Wigner Institute for Advanced Pharmacy Practice, Education, and Research at West Virginia University. That's a long one. And Dr. Susan Bessette from the president of West Virginia Drug Intervention Institute, and her wonderful Kat Newman will also be hopefully making a guest appearance. And Ed Karras, Chief Medical Officer, and Jason Landers, SVP of Medicaid for the health plan in West Virginia. So now I'm going to ask each panelist a question or two, and try to limit your responses to a couple of minutes if possible. And then following those individual questions, we'll have more of a panel discussion. So let's dive right in. So Mayor, my first question is for you. Your city of Huntington was once considered the capital or the epicenter of the opioid crisis, but now it's really viewed as a model for recovery and addiction treatment. And so what is the foundation for your success, and is it a model that we can replicate elsewhere?
Certainly it's a model. Thank you. And thank you, Courtney, so much for letting me be a part of this conversation, particularly going through COVID-19 pandemic. The one thing that we all have come to learn during this time is the importance of connection. So important to have connection. With those of us who have been involved in fighting the addiction epidemic came to understand that before. One of the reasons that Huntington became, quote, known as the epicenter of the opioid epidemic is that one thing that we did early on that frankly would cause a lot of public officials, elected officials, to decide to step back is that we had the general sense, if you name it, you can own it. If you own it, then you can control it. And our sense is that what we have to do is actually talk about the issue and state it for what it was. And we found that there were an awful lot of silos in our community. There was a lot of effort to fight addiction and the opioid epidemic, but there wasn't a lot of conversation crossing each other's paths. So what we found is that when you're talking to one another, you're starting to establish trust. Collaboration leading to trust will lead to additional conversation, but the ultimate result are partnerships. And what we found was by having that label of epicenter of the opioid epidemic made us awfully determined to change that dynamic to be seen as the epicenter of the solution to the opioid epidemic. And frankly, where all of that actually came out is I was being interviewed by a New York Times reporter up in Cleveland, and she went, "Oh, Mayor Williams, Huntington, West Virginia. That's the epicenter of the opioid epidemic." Now, those of us in West Virginia would understand how I responded as that was a truly bless your heart moment for us. And that's when I said to her, "Well, ma'am, we don't quite see it that way. We see that we are the epicenter of the solution to the heroin and opioid epidemic." So what we've done is we knew that we had an awful lot of pieces in place to be able to address this, but as we started talking to one another, it was amazing how we were able then to start demonstrating that if a small town like Huntington, West Virginia can do things to be able to bring healthcare and public health and business and bodies of faith, houses of worship, and neighborhoods talking about it, then we can own it, and then we could start to control it. And as a result, we started seeing our overdoses drop significantly. Of late, where we are, because of the pandemic, our overdoses have gone up by 13%. They're not nearly at the levels that they were before. But we had 3 years in a row of 50%, 40%, 60% reduction in overdoses. And what we have to do, what I've seen is that we have to link COVID-19 and public health with the opioid epidemic or the fight against addiction and bring those together. And we have a foundation to be able to do this.
I really appreciate your comments about connection and partnership and, all working together. We really need a public and a private sector response to be effective, in this fight. Have you seen the impact of stigma in Huntington? And I wanted to ask you about that and how you've seen that change or not change in terms of addressing the opioid crisis in your city.
That's the one part that breaks your heart, because you see individuals who are truly wanting to be able to heal. We're watching the effects on family, stigma. I asked somebody one time, I said, why don't we create an institute on addiction, much like we have institutes on cancer research and institutes on Alzheimer's and institutes on diabetes, and there's an institute to fight addiction. And they said, but addiction has the stigma that the others don't have. Interestingly, the former First Lady, Melania Trump, came to Huntington to visit a couple of times. We had a panel discussion in one of her visits, and as we were walking away, I was thanking her for coming once again to Huntington and shining a light on the issue and not being afraid to address it head on. And she looked at me and said, Mayor, said, the one thing that we have to fight to be able to win this war is we have to fight stigma. I think that just said it all.
Yeah, I couldn't agree more. I often think of what is stigma, and my own definition is a lack of compassion. And we need to start infusing practices and policies with compassion. And then maybe our, response will be different. And I think it's heading in that direction. So I really appreciate your insight.
Thank you, Courtney. To that point, any public official, anybody in a leadership position, I heard a group out of Massachusetts say that the single obligation that we have is we have an obligation of leadership. If we allow the stigma to live and to continue, then it will grow. If we approach from a heart of compassion, evidence-based compassion, I think that we can defeat this.
I agree. Well, thank you so much for all of your hard work and your leadership. As you mentioned, we need leaders, more leaders like you. So appreciate everything you're doing. Now I want to turn it to Nick Mercadante and ask about his role at Pursue Care. And, the telehealth piece. We've just heard so much about this growth and expansion of telehealth under the current pandemic. And I'd love to just hear more about how you combine telehealth and the virtual care technology with counseling, medication, pharmacy services for SUD. And how have you been able to respond to the ongoing, demand? And do you think that demand for telehealth will continue? Sorry, those were 4 questions in one.
I'll start. Well, I guess first, thanks for having me on and talking about this. And I wanted to kind of go back to something that the mayor was saying, just in terms of where solutions start, and it kind of informs where we started with Pursue Care. So full disclosure, I'm not from West Virginia. I'm actually from Connecticut. But I have ties to West Virginia, and our organization has deep ties to West Virginia and Huntington in particular through our co-founder, Tom Mennigan, who's on here today as well. And, something that the mayor was talking about, I think resonates with everything that we're doing now in terms of using technology to help to solve some of these problems. Most solutions start in the community where the problem is. They don't start way outside. They don't start because, the federal government or the state at large says, you know what, there's a problem somewhere. It starts in the community because they know what's going on there. The people there understand it. And then at some point, hopefully, the sentiment changes if that's what needs to happen. And I think that that's starting to happen and has really picked up steam. Putting COVID aside, has really picked up steam in recent years, just in terms of destigmatizing substance use disorder, thinking about how we can solve the really a healthcare crisis, more so than a moral crisis or a criminal crisis. And approach it as a chronic illness and something that's impacting families and communities with some level of compassion and understanding, as opposed to saying this is a problem over here and I'm not ready to be a part of it. And that takes an entire community kind of circling around it and working together. So, that resonates. What the mayor was saying resonates. And that's how we started Pursue Care, really, is, Tom is from Huntington, had about a 35-year-old pharmacy in the community, came to myself, my father, and some other people that were supportive, and said, look, I think that there's some work to be done here. And I think that we can use the pharmacy in Huntington as a starting point for that. And myself, bringing some of my past background and experience as a healthcare attorney and an executive that is focused most of my career on delivery models for healthcare, and for behavioral health specifically, I said, absolutely, this is part of a solution. Let's dig into it. Let's see what's going on in the community. And that's how we got started with Pursue Care and working on, okay, how can we get more and better evidence-based healthcare to people in need in a way that's destigmatized and reduces barriers. So that's the foundation and the mission for what we started doing. We started doing this in 2019. Now I feel like I've been doing it for about 20 years. And now we're being looked at as kind of a leader in this movement towards telehealth, and how can we leverage telehealth and virtual health solutions to solve the problem, which I think is great. And we're excited to be that. But it really did start in a community saying there's a problem here. How can we solve it? There's numerous barriers, putting aside COVID, it's transportation, it's education, it's the stigma element and the shame element. It's that clinics are overloaded and there aren't enough resources directly in folks' communities. I've seen one study that says only 5% of people living in rural communities actually get their substance use disorder treatment right directly within their community. They have to go someplace else. 5%. That's a major problem. In Huntington being, getting further ahead, you look at the rest of West Virginia, that's an ongoing problem. So that's where we started and came in. And, COVID unfortunately kind of threw, rocket fuel on it, because of the level of isolation that people were experiencing. And because so many people, they just didn't know where to turn, right? Or the places that they wanted to turn, or the places that were helping them previously were suddenly telling them, look, we can't treat you the same way that you're accustomed to. You can't come in anymore for group therapy. You can't, we're closing our doors. We ran out of money. We can't afford to pay our employees. Our census is down, whatever. All those things are impacting people as individuals. So what we've tried to do, now going to, I think your second or third question is, how has telehealth kind of evolved during COVID and where is it going? What we have tried to do is circle around the patient and put the patient in the middle and center all of our focus around the patient. I think a lot of telehealth during COVID, candidly, has been a scramble about how do we retain patients? How do we keep our practice alive? How do we reach people without having them come in and creating a risk related to COVID? Because we were established as a 100% virtual solution, we were already thinking ahead to, let's focus on what the patient experience is for treatment at home. How can we treat people at home in an innovative way, but most importantly, an effective way, so that they can reach long-term recovery? Not just trying to, do a session and bill a visit and, hope they show up, but actually putting tools in place to innovate the care model and then looking at the outcomes. Are we engaging patients better? Are they showing back up for their appointments? Are they satisfied with the experience of telehealth? Are they getting everything they need, or are we creating new barriers? That technology, for instance, or I don't have Wi-Fi, things like that. So we've tried to go through and check different boxes around the patient and solve each of those problems. And I think we were fortunate that we got a head start on that. Others that are now starting to do it are learning from, organizations hopefully like us and ones that were out in front of it. And what I hope to see beyond COVID is a continuous evolution of telehealth around the patient, where they continue to bring more and better resources to the patient in their home so they can continue care at home in a destigmatized way. Because let's face it, those barriers that existed before COVID are still there. Stigma, transportation, childcare, can't take 3 hours out of work to go to the clinic. All those things still exist. They're not going to go away when COVID's gone. So hopefully telehealth will continue to be a solution that can solve for that. We just have to propel it forward and continue to focus on the patient experience as we do it.
I really appreciate all of your comments there. And I think, like you said, the pandemic has put just rocket fuel on this, telehealth, delivery system for patients. But I do, I also think that it really helps with stigma, which is what you touched on. We're treating addiction like any other disease. You can call and have a video chat with your provider. They can call in medication for you. You can go pick it up at the pharmacy, right? Like that's a normal patient experience. And it sort of normalizes behavioral health services in that way. So just appreciate everything that you're doing, and Shatterproof certainly stands at the ready to help support that. I'm just looking at the interest of time. I do want to get to all the other wonderful panelists that we have. So Casey, I'm going to turn it over to you and ask about your opioid stewardship initiatives. And, now that you're being called upon with COVID testing and vaccinations and rollout of the vaccine, there's so much demand on your pharmacists and on your pharmacies. So how are you juggling these initiatives at Walgreens? And which are so critical to people in West Virginia and all the other states that you operate in?
Yeah, thanks, Courtney. Appreciate it. And like Nick, I'm not from West Virginia, but I'm here in large part due to folks like Tom and the good folks at DisposeRx. But obviously, we're in every community and have roughly 95 stores in the state, and 2 of them in Huntington. So, Mayor, appreciate your partnership there as well. You bring up a great point, Courtney. These 2 converging issues and pandemics and epidemics are really problematic. Nick, you spoke perfectly to the isolation piece and some of the other aspects. We embarked on the first of its kind in-store disposal program with kiosks in our stores back in February of 2016. We've since added a total of, 1,400 kiosks nationwide. 12 of those are spread out through our 94 stores in West Virginia. That was our first endeavor into how can we be part of the solution as it relates to the opioid epidemic, right? We're the source of the medication. Let's find an end-to-end solution for the consumers to get rid of their medications, whether it be controlled substances or not. We further embarked with William and his team at DisposeRx and Carol and the folks there to add an offering to all of our 9,000 plus locations across the country, offering the DisposeRx packet at no charge to any customer who's filling a prescription at Walgreens. So we sort of built out solutions as this issue evolved over the last several years. Obviously, we, as you well know, pharmacists play a big role with respect to naloxone and the dispensing of naloxone without a prescription. So a lot of legislative and regulatory changes need to take place to make that happen. So the good folks at Tom's old employer and ourselves and others embarked on that. And are now offering naloxone without a prescription at all of our stores across the country as well. So a lot of foundation laid over the last several years to ultimately get to where we are today, to your point, and trying to manage both of these. As you all have read and seen, Walgreens is intimately involved in the long-term care facility rollout of the vaccine. It's those same pharmacists in those same stores helping manage chronic pain conditions, helping manage folks coming in to dispose of their medications, consult with folks who may be caregivers of someone who is known or perhaps inclined to be addicted to pain medication, leading to obviously other more hard drugs. It's those same pharmacists. So we're trying to strike that balance of making sure that we're very responsive to what's happening in the pandemic over the last 10 months, but also not losing sight of our core mission of consulting with our patients and obviously dispensing appropriate medications. Just along the same lines as Nick, a lot of activity on the app. You can use our Find Care, similar, again, using telemedicine. We've got pain management pain management solutions within that app. We've got a number of other mental health consultations via the app. So we're trying to bring a lot of different things to life all at the same time, while still focusing, just like all other healthcare providers, largely on the pandemic, and providing, whether it be testing for COVID-19 in the early days, in the spring, but now obviously focusing on the vaccine. So just real quickly, we're up over 1.5 million vaccines administered across the country. 17,000 of those vaccines have been administered in West Virginia by our pharmacist. West Virginia did opt out of the federal program for long-term care facilities, but Walgreens was partnered up with the state and did some good work with them in some of those facilities, as well as in our stores as well. So just super excited about the partnership. Again, we stand ready to try to continue to manage both of these ongoing and increasingly difficult pandemics and epidemics in our stores. So hopefully that was helpful. I know we're running short on time. You've got some great other folks you want to talk to. So happy to answer any questions towards the end. But thanks again, Courtney, and thanks, Carol.
No, Casey, that was wonderful, and I would love to work with you offline on the naloxone access laws. That's something our ambassadors, our advocates are really passionate about. Many of them have lost children or have, children in recovery at home with them right now, and so making sure that naloxone is readily available is of critical importance, particularly now with the spike in fentanyl in Xanax and stimulants and pretty much everything. So just appreciate your work on that. And you touched on something too, and I think we really undersell how brilliant pharmacists are and what they can do. And if I do anything on this call, I'd love to share my respect for pharmacists, but also let's help arm them with tools and resources to be a part of the solution. And I think, we're working, I work on state policy around getting long-acting injectables for serious mental illness and SUD, allowing pharmacists to inject those just like they would a vaccine. And so I think that's really important. They can be a part of the solution, and it only helps to destigmatize the disease as well.
Totally agree. No, and you're absolutely right. And if the pandemic has done, the COVID-19 pandemic has done nothing, it has just further elevated the profession of pharmacy. And I think it's brought forward a lot of the skill sets that were maybe hiding back a little bit. I think those on this phone call certainly know it. Tom certainly has been a champion of it for decades, but I think it's really brought to light the ability that these folks have to deliver real quality healthcare at some of the most accessible points in the community. So a lot of good work still to be done there. So would love to partner with you on that for sure.
That sounds awesome. Thank you. Now I want to turn it over to Krista Capehart and, ask about your role in education. And, we've seen your name in the news a little bit recently in West Virginia as you're leading this statewide initiative to roll out vaccines to K through 12 teachers. So how did you get engaged in those efforts? One, what's going well, and what are some of the challenges that you're facing with that engagement?
Sure, absolutely. Well, my role at WVU at the School of Pharmacy is half of the hat I wear. The other half is actually at the Board of Pharmacy. I'm the Director of Professional and Regulatory Affairs at the Board of Pharmacy. And so because I have so much contact with many of the people on the webinar today, as well as all of our pharmacies throughout the state, it was just a very obvious connection when West Virginia did decide to go a slightly different route, because we have a mixture in West Virginia of both independent and chain pharmacies. It's about a 45-55 split, it just became very obvious that we needed to utilize all of our partners, as the mayor and many of our other speakers have mentioned. Really, we're talking today about how the pandemic and our opioid epidemic are colliding, and we need to utilize all of our resources. And the pandemic is truly no different than the opioid epidemic. We really needed to utilize all of our resources. We were very fortunate to have Walgreens partner with us, as well as all of our independent pharmacies throughout the state. And so we were actually able to partner up and be the first state to complete our long-term care facilities. We did so in 15 days, all 214 facilities, and we've rolled out the same model to vaccinate our K through 12 teachers over 50. We'll have completed over 20,000 vaccinations in 2 weeks. And so the key here is truly teamwork and collaboration across the entire community, and a community outreach approach. It's not about where you're coming from, but it's recognizing that you can utilize all of the resources within your community, and that the community knows itself best. I think that we have done so with the opioid epidemic, and really expanding our naloxone access laws. Even just in the last legislative session, we were very fortunate to expand naloxone access by enabling our evidence-based community groups to be able to do distribution as well, which has really been an opportunity for us to increase naloxone distribution. And so we've been very fortunate. We also have a project ongoing at WVU with the School of Pharmacy, where we're connecting. We're trying to we are setting up a network where we'll utilize individual pharmacies or multiple pharmacies within each county, just kind of as a network resource where additional information about resources can be found. So working on multiple levels. But I think the big thing really is recognizing that you need a community-based approach, whether you're fighting the pandemic or the opioid epidemic, and that everybody brings something to the table.
I really appreciate that community-based approach. And I think it's just incredible what you've done with the COVID vaccine so far. And I think every parent that has young children should be sending you a thank you card for getting their kids back to school.
I've heard from a lot of my former teachers.
That is so brilliant. And I'm so concerned about all of our educators. So thank you for making them, a part of the rollout. That's awesome. And just, thank you for your partnership on the pharmacist front. I think it's very exciting. And just sort of pivoting to this education component, Dr. Bessette, I wanted to get your take on, as president of the West Virginia Drug Intervention Institute, education is such a key component of what you're doing as well. And so can you speak a little bit about the drug prevention side of this? And then what type of community collaborations are needed from your perspective to be effective at that?
Thanks so much. And I'm honored to be here. And I will say that Dr. Krista Capehart is being very humble. She is a rock star and a huge reason of why we are where we are. She's also a personal friend, so I'll just self-disclose that. But she's awesome. She's just awesome, and very honored to be here with the others as well.
Have you met Newman?
No, she has not met Newman. She's heard about Newman. But I will say that first and foremost, my roots are also in pharmacy. I'm not a pharmacist, but I'm the former assistant dean at the University of Charleston School of Pharmacy. And so when I started my work in prevention education, it really started with sending pharmacists who were in pharmacy school out into school systems, into particularly elementary schools, to educate young children about safe medication use. And we had been doing that for some time at the University of Charleston. And then in May of 2019, I took this role as the president of the West Virginia Drug Intervention Institute. And we've continued that work. So we have several programs. One of those is a pre-K kindergarten program called Don't Keep Rex Around, that uses a talking avatar pill bottle to talk to young kids about medication safety. And Joe Murphy, who's on the call, is really the creative genius behind that. But that program utilizes technology to talk and interact with the kids. Rex interacts with the kids. We have materials that then go home with parents. We do provide medication disposal kits to school offices so that parents can pick those up should they want to dispose of medication. So that's one of our biggest programs. We really have had to be innovative and use technology, much like everybody else on the call, as a result of COVID. When school systems close, you can no longer send pharmacy students into schools to do that education. And so we've had to find some alternative ways to do that. We also have our 3rd grade program, Smart RX, and with the help of the Mayor Foundation, just launched an online training for college students, because we know not only are opioids a concern on colleges, but stimulants are. That training also provides naloxone training for college students as well. And all of that is asynchronous and online through a learning management system. So we've been very fortunate that we have a technology partner like Murphy Media, and we're able to migrate and use innovation to deliver a lot of these programs online. That's not to say that there haven't been challenges. Kanawha County Schools has changed their school calendar more times than I choose to count as a parent or as a person in this role. But I think one of the things that we're looking at, there's 2 things that the Institute does very well, I think. One of them is education. And what we're really looking at doing is educating people about safe medication use across the lifespan. We developed Rex not in a vacuum, but because we had a county superintendent who came to us and said, I had 2 4-year-olds overdose by taking their grandparents' medication, and one of them died. I need this curriculum sooner rather than later. And so we really started looking about working with the Department of Ed and other agencies to figure out, how do we make this message appropriate for young children in a way that they're going to know that they don't touch this stuff without a trusted adult. So we very intentionally made Rex so he's not Mickey Mouse. He's not going to high five you. He's not going to give you a hug, but he is going to share an important message, kind of like a Smokey the Bear. And so we really were intentional about the way we've created that. And we continue to focus on that intentionality as we explore other ways to reach kids. One of the things we're working on right now is something called Spark. Seeking positive alternative realities creatively that will get to middle and high school students and help them to use technology to make positive choices and learn more about how to make positive choices. We've also partnered with pharmacies, Fruth being one, to make medication disposal free to anyone who comes into the store. We're hoping to do a pilot program in 2021 where stores will dispense naloxone automatically with the first opioid fill. We're having some conversations at the state legislature about co-prescribing and how do we do that without passing down the cost to the patient and the pharmacy. And so those are things that we're advocating for. The other thing that we're really focused on is access to care and harm reduction. And so that naloxone education piece is there. How do we educate doctors and pharmacists about the importance of co-prescription and dispensing? How do we educate grandparents about how to store medication? Because we know that that particular age group is less likely to store medication properly. They're more likely to have multiple prescriptions. And so you're taking children in West Virginia out of homes that we're deeming as unsafe, putting them in homes that we think are safe, but that previous home misusing prescriptions and other drugs was normalized. Well, now they actually may have more access in the safer home. So how do we educate across the lifespan to help people understand that you don't keep medication around? We know that most people started, unfortunately, misusing prescription medications and then later heroin because they obtained that medication either knowingly or unknowingly from a friend or a family member. So that's something that we're really, really passionate about. We're very lucky to have a media partner that works with us, and we're able to say, okay, because COVID changed the game for us. We couldn't get into schools. We couldn't get face-to-face with kids and parents. And so you have to look at those alternative delivery methods, just like you do for treatment. You have to look at that for prevention, and also for educating pharmacists and physicians and doing some academic detailing around the issue of disposal, because I completely agree with Casey. Pharmacists are in the best place to do that. And the best place to talk about disposal is at the time of access, at the time of dispensing. And so if we can really get that message out there and really train our current pharmacists and our future pharmacists to be well equipped to do that, I think we'll be in a really, really good place. There's a lot of challenges associated with the work we do, but we couldn't do it without collaboration. I think at one point, there's at least 5 people on this call that I've called and said, hey, we're trying to do X, can you help us? Or I'm trying to do this way, where do we go? You know, what are your thoughts? So there's not a day that we make a decision in a vacuum. We all have to work together. This is a very large, comprehensive issue. So how do we deal with a pandemic and an epidemic at the same time? We all have to work together to do it. And that's education, that's prevention, that's treatment, that's access to recovery and harm reduction. And you can't do that without the help of a number of different private and public partnerships.
You're speaking my language. Thank you so much. I think it's so important to talk about the prevention and education aspect. And this is near and dear to my heart. I used to run the METH Project and the National Youth Anti-Drug Media Campaign, Above the Influence. And, you know, the federal government in the last 15, 20 years has cut youth prevention by close to 70%. And, you know, we don't have these robust, comprehensive education programs in schools like we used to. You know, I grew up with DARE. I won my 6th grade essay contest for DARE, and I gave a presentation at the school assembly, but like that had a major impact on my life. And we don't do those things anymore. And it's so hard to reach teens and young adults in particular, you know, with the different digital media platforms. So I just really applaud what you're doing. I think it's so needed. And I think parents, you know, don't know how to talk about these issues, particularly with young kids. So, you know, you doing the research and putting together the messages is incredible. And I'd love to learn more, you know, and see what you're working on.
And I think we know more about prevention now, right, too. So we know that telling kids just don't do drugs, that's not going to do much for us. We have to create opportunities for kids to have outlets, and that starts at the community level, that starts at the school level, that starts in the home. And so one of the things that we've been really focused on is there's a lot of programs in particular for students in sports. How do we capture that group of kids that is not maybe that sports minded? I'm thinking of my 9th grader who is more artistic, and so there's lots of ways to turn those kids on using technology and different outlets. And so I think all of that has a place together. We know if you look at the numbers of the kids in West Virginia that are struggling just with mental health issues since this pandemic, it's just enormous. And we have a lot of work to do, and we're going to continue to have a lot of work to do when we're able to say this is finally behind us.
Yeah, couldn't agree more. And, you know, 90% of addictions begin in the teenage years. We know that now, which we, you know, didn't necessarily know 20 years ago. And so it's a huge opportunity, and we need to make the investment from a federal, state, and local level to make that happen. I just got distracted by the excitement around this prevention talk. I love it. And I hope, Dr. Bessette, you will be attending the Community Anti-Drug Coalitions of America Forum next week. And if you're not, I will send you the info, because it's wonderful community prevention materials and resources. So finally, I know we're getting to the end of our panel discussion here. I want to bring in our last 2 panelists, Jason Landers and Ed Karras. We really want to hear from the payer perspective. This is so critical to this issue. And you guys are covering a lot right now, from the COVID, pandemic to the opioid crisis and the behavioral health space. And, would love your perspective on what you're doing to support your members and also your providers during this unprecedented time. And whoever wants to start, Jason or Ed.
I'll start, and I'll let Dr. Karras add some color if that's okay with Dr. Karras. But we, as a payer in West Virginia, this has been a very interesting and challenging year. Substance use disorders are a terrible problem in West Virginia, and we heard the mayor talk about his trials and tribulations, and they're well documented. And there's been wonderful things happening there, and just as the education efforts and the prevention efforts started to take hold, and the processes and treatment facilities were opening in West Virginia to treat those who are addicted. We get the added burden of the pandemic tossed upon us, and it's brought some interesting things. We talked a few minutes ago about telemedicine, and telemedicine has been a game changer, and I think everyone's seen it. And it probably did start in that vein of how do we kind of keep our patients. And what we've learned is, we had our own concerns as a payer on what this would look like, and I think it's almost been a little pilot project of what would the world look like if you couldn't leave your house, and it's really done some amazing things, and it's transformed the way care is delivered, even care for our substance use disorder patients. But along with those many changes, and a lot of them very positive, and creating access to physicians and medicine that maybe some people didn't have, substance use disorder and treatment, a very important component of it is that in-person, face-to-face encounter and group encounter activity, and the pandemic really kind of shut those things down. So we were finally making some headway. There were facilities being opened, and we were trying to navigate that space, and then the rules basically changed. So that was certainly a struggle that we had. And I think that as we heard, telemedicine, and there are app-driven programs that are really being created and perfected in this substance use space in particular, and we are examining those and looking at what those options will look like for our members as well. It's been a tough year, and you throw on top of what our patients really are battling, and now transportation is even more difficult. Face-to-face is nearly impossible. All of those things, and remember, in West Virginia, the bulk of the health plan membership are Medicaid members, and these members already have challenges with these other issues that really kind of exacerbate the problem, like homelessness and hunger. And fortunately, THP, we've made an effort to donate to food banks, and we're trying to address those other problems that really just kind of again exacerbate the drug problem where we can. So it's been a challenge. It's been interesting, and in support of the providers in the state. We've worked in concert with the state of West Virginia and Medicaid, and we've increased payments to providers to help them through this kind of crisis. The pre-authorization process for every service was removed. So we've done what we can to remove the barriers, the traditional barriers to care that maybe a payer would put out there. We're trying to just make sure that the appropriate care can occur whenever it can. So, Dr. Karras, you want to add any color to that, or?
Yeah, a couple of things. So to add to that and to take it in a little bit of a different direction, I oversee a team that includes nurses and social workers and pharmacists, and they're all people that have rich experience in the clinical world, but now they're in the managed care payer world, and they understand that they're not the people on point for providing direct care anymore. And it's an important discrimination because I've heard the word partnership many times during this conversation, and my team certainly looks at itself as partners, really trying to understand what the plan of care is, and then working with the member to make sure that he or she understands that plan of care, and then doing what we can to get them back to care. And that's the one thing I think that's a little bit about a payer that sometimes we're misunderstood. But we really also want people to get in for needed care because we feel that results in the best outcome. So that's my first point. My second point is we really train our staff to look at members. We would call them members, you'd call them patients, holistically. And so substance use is a medical problem, just like diabetes is a medical problem, hypertension is a medical problem. But no matter what your medical problem, if you can't get what we now call the social determinants of health taken care of, it's really going to be challenging for people to get other things taken care of. And so our instructions to our staff, and they do a really nice job of carrying it out, is to actually have very open-ended conversations, meet people where they are, find out what their issue is the day or the hour that you're talking with them, help them to solve that issue, build some trust, and then ultimately you'll be able to get to the point where you might be able to talk about the medical issue. But if someone's having food insecurity or homelessness, especially for a Medicaid population, like Jason was saying, who's very challenged, you have to be able to help them to resolve those issues, or you can't even get to the things that, we as clinicians would feel are the things that we want to talk about. And there's just no script for it. You just can't get to your questions about substance use disorder and have that conversation first. You really have to just pursue the conversation from every angle, but most importantly, pursuing it from the angle that's most important to the member.
It's such an important perspective. And I think, as we sort of talk in our own echo chambers, we forget about that, the homeless populations and people who are desperate for food, and sort of where that fits into the spectrum of health and outcomes and, quality care. So just really appreciate that. Something we're working on at Shatterproof is really trying to socialize the collaborative care model with states and with Medicaid agencies across the country, so that we're treating addiction at stage one, and we're really arming care coordinators, primary care doctors, social workers with the tools to identify and then treat SUD and also mental health, because the comorbidity is so prevalent. And so, Ed and Jason, I'd love to chat with you about what that looks like, potentially in West Virginia as well, and just hear your thoughts from the primary care setting. And as you're talking about this sort of integrated partnership, right? You mentioned different clinical teams coming together in a coordinated approach. And I think that can have a huge impact on outcomes and also on financial savings too. So Is there
Courtney,
anything?
if we can try to do one joint or panel discussion, I think that would be great, and then
Sure.
we'll tie it up. Yes, thank
You
you.
know, I think what I want to ask here, we covered a lot of bases today. And what I want to ask is, where are the gaps, particularly in West Virginia, you know, in terms of funding, treatment access? What are you seeing? What are the gaps, and how can we work together? And if somebody doesn't raise their hand, I'll just call on you. So, okay, Nick, go ahead.
I'm the good student who raises his hand. So, you know, one of the things that we work pretty hard at, and it's part of our model, is we try to be a connector or a bridge with other health partners. So I mentioned earlier, I talked a lot about community. Our focus is getting into the communities, working with community health centers, hospitals, primary care, urgent care, any place that can act as a front door for somebody with substance use disorder who's struggling and doesn't necessarily know where to turn, but just so happens to turn towards maybe someplace that can't help them directly. You know, if we can be there and use technology to support that, and we do it, you know, we put iPads on site with a portal so that they can rapidly triage and pre-assess and potentially refer to us for on-demand care if that's what's needed. So that we can help get medications or help at least get the patient on the journey before they walk out the door and they're discharged. That's the biggest area that we've seen, and really why we put so much focus on it is so often folks just get disenfranchised with their healthcare experience because they tried once, or maybe they tried 10 times, and they either got turned away or bounced around or kind of put through this fractured model. And to tie it to what the folks at the health plan were talking about, you know, we're all on the same team. We want to get to the patient and provide good care and keep them in treatment, because ultimately what that will do is it will reduce waste in the system and cost associated with that person bouncing around. Or a much worse outcome of somebody getting completely disenfranchised with healthcare options completely and never coming back, and then ending up in an overdose type of crisis. So I think that's the biggest one to solve, is how do we tie more of the continuum together? You know, our part of it is the specialized treatment and using the technology, but maybe the other parts of it are the hospitals being open to working with organizations like us and promoting that, and putting some discharge planning or peer support in place to convince the patient, hey, this is what you could do next, so that you can go home with a game plan.
I love what you just said, what you touched on at the end, recovery support, peer counselors, and sort of meeting people where they are, and that readiness to change. They're such an important part of the conversation. Dr. Bessette, did you want to say something? I saw you came off mute.
Yeah, I think for me, there's a lot of gaps, but I think the biggest issue that we have to tackle is stigma. And I think until we tackle that and unpack it, and what I see is a lot of funding going to anti-stigma campaigning, but not a whole lot of collaboration across the state about what that message looks like. Seems like every grant in the world has something in there for an anti-stigma campaign. And so you've got 65,000 different messages about stigma. The state's doing a really nice campaign, Back to Life West Virginia, but that's focused more on getting people into medically assisted treatment. So when we talk about stigma, there's a lot to unpack there. There's stigma in general about addiction. There's stigma about treatment. There's tons of stigma about naloxone. You only need to read the comments in a random newspaper. I don't advise doing that if you want an uplifting day, by the way. But there's just a lot of stigma to unpack. And I feel like there's a lot of people who are trying, I hate this metaphor, but trying to eat the elephant at the same time. And I think
Never heard that metaphor before.
I hate the phrase "eat an elephant one bite at a time," but it's accurate in this case. And so I think we need more collaboration between public and private entities about what that anti-stigma messaging is, and it needs to be consistent throughout the entire state of West Virginia. because we've got to work on changing some hearts and minds. And I refuse to believe that it's not possible. And maybe that makes me an idealist, but I really think the stigma is the key. And then we'll see some of these other gaps become less of an issue because people are more willing to work toward it.
I love that. And, you know, we're actually at Shatterproof, we launched a stigma campaign with the state of Pennsylvania. But what we're doing is utilizing evidence and tracks. So we're talking to providers about, you know, what's the provider stigma, right? Like, I don't want these patients in my waiting room. Okay, well, that's a whole different level and a different message than, you know, a public message, right? So,
well, I will tell you, when we were looking for space for the DII, when we were looking to relocate off of the University of Charleston to downtown Charleston proper, I actually had landlords ask me, well, what kind of services are you providing? Are you going to have those addicts in here? So of course I immediately scratched them off the list, but it's out there, and it's a huge barrier to the work that we are all trying to do.
And it's you know, compassion, right? These are our friends, our colleagues, our children. So with that, I know we've gone over. Carol, don't kill me.
No. It was a great discussion, and I am just sorry we didn't get more of the panel discussion, but I can't thank each of you enough. We will be back in touch with you. Obviously, great work is being done, more to be done. We're not there yet, but I think, as we've all said here today, collaboration is the key. And again, thank you so much for being here, and we will follow up with each of you. Take care and stay well.
Thank you. So nice to meet all of you, and thank you for your good work. Stay safe.
Thanks
Thank
all.
you.
Thanks, Courtney.
Thank you.